the non-invasive airway, and they're going to switch gears and really focus on rapid sequence induction with intubation and some of your backup methods. I actually had it arranged that I had a giant glide scope on a stand, and I went downstairs during break to get it from the paramedic program, and they have no idea what happened to it. And I swear to God, I didn't take it. Okay, I have no use for a glide scope on a giant stand, but apparently it's missing. So I was going to demo it up here. So anyway, but we're going to concentrate on RSI and intubation techniques. Okay, so let's do a warm-up case. Let's get your mind switch gears from all that cytology stuff and colpos and all that to this. Okay, you guys read the scenario, please. I literally saw a patient just like this on Saturday in Uvalde. Literally, just like this. This was a male patient. She was deep frying a turkey, for real. Okay, what do you think? It says, how do we begin managing her airway? So we look at her. Does she look like she's tripoding and distressed right now? Can we tell if she has singed hair on her face? I mean, we assume so, right? What kind of degree of burns is this already? Yeah, this looks like full thickness, right? I don't know, looking at her in just this picture, you don't know what her original skin color is, but full thickness burns look brown, leathery, charred. She's already peeling. You guys can appreciate all that. If it's just blistering, that's a partial thickness, also known as second degree. Once it's peeling and it's charred and leathery, that's a full thickness burn. So she's got full thickness burns, at least from here up, that we can see in this picture. But she looks comfortable right now. What do you think her clinical course is going to be? What's next for her? Surgery and debridement, right? So do you think she's going to need to be intubated at some point?
Yes.
Probably. But right now she's maintaining her airway. So what will we do first because she's stable right now? Yeah, we can give her low oxygen, right? And this is really important, and this is the differentiating factor from the guy I saw the other day. Very similar presentation, 50-year-old something. He had a t-shirt, shorts, and cowboy boots on, and he was working, he was filling up this fueler with diesel, and it was empty, and it was so hot that day that when the fuel hit the empty, heated vessel that he was filling up, it imploded, and he had a flash fire, but he was not in a closed space. So he came in looking like that, leathery, charred ears, hands circumferentially burned everywhere. So I calculated about 27% TDSA, full thickness burns. Face, facial hair, everything was burned, but he didn't have soot when he coughed. He wasn't wheezing. His voice wasn't hoarse. So did I need to intubate him? Did I want to? Maybe a little bit. Okay, but I didn't because I called the burn center here at BAMC, talked to the burn surgeon, told him how the patient was presenting. He's like, don't intubate him, we'll do it when he gets here. And that's fine. Did it make me a little nervous? Yeah, because I would rather secure his airway and make sure it's secure in a stable environment before I put him on the back of a moving helicopter. So my clinical gestalt said I needed to secure the airway. And if I did in a burn, like this patient, you need to do an 8.0 ET tube. Anybody know why you want to go so big? Because they're going to do bronchoscopy once they're admitted. They're going to have to go in there and look at the lungs and do a bronch at some point. And so the only way they can do that is through an 8.0 tube. So in burn victims, we try to go the biggest you can, which is an 8.0 tube. All right. Anyhow, for her though, and for him, we just gave oxygen support. A little bit of nasal cannula, make sure their sats are okay. But it's really important that you ensure that they're not wheezing. They're not. They don't have black soot in their like sputum. And they're not hoarse, because those are signs of what? Airway involvement. Who gets airway involvement? So most of the time when there's a fire, they hold their breath, right? So, but if you're trapped in a confined space, at some point you can't hold your breath anymore. You take a breath. Those are the people that have the inhalation injury. So house fires, vehicle fires, they get out right away. People who are enclosed or trapped in a small space, they're the ones that get inhalation injuries. Flash fires rarely do it, even though they have all the singed hair and stuff. You got to ask those other questions, all right? All right, so we've talked a lot about this already. In general, airway management's in two major categories. We have the non-invasive stuff. Give me some examples of non-invasive airway. Yeah, we just did it. Nasal cannula, oxygen. What else? What are non-invasive? Yeah, positioning your patient, right? What else? believe that BiPAP is non-invasive. In fact, it's called non-invasive positive pressure ventilation. Good. Any of these things, right? These are all considered non-invasive. Your extra glides, your EPA, your OPA, your eye gels, all those are non-invasive. Even though they go into the airway, they're considered non-invasive. Invasive is intubation, crikes, tracheostomies, things like that, or even needle crikes, which is what we do in kids under the age of 12. If they have massive facial trauma, we'll do a needle crike on children. Those are all invasive. Okay, I'm not going to get into respiratory failure much, but just know that if somebody has hypoxia with or without hypercapnia, so you could be hypoxic like somebody threw a giant PE or something, and so the treatment is optimizing oxygenation, whereas they can also be hypoxic plus have high CO, carbon dioxide, in which that's a ventilation problem. So we have to support their oxygenation and their ventilation. Is this too much today? Okay, all right. So we talked about this already. How do we assess somebody has a patent airway? Yeah, can they conate, right? And swallow their own secretions. Those are signs that they're doing pretty good. So that's how we say, hey, how you doing? Are you doing okay? Yeah, I'm okay. And you can tell right away their effort, if they're hoarse, things like that, or if they're wheezing. And then, like we said earlier, one way that we can intervene on an airway is just put your patient in a good position. And that's that sniffing position, right? On their back, sniffing as long as they're not altered. All right, we want them on their back, and this is a little sniffing position. We extend the head and neck, as long as they don't have a C-spine injury. And you can put a towel under their occiput. Some of these people have these Cro-Magnon type heads, and so you can't even put something under their occiput. You have to like roll up something and put under their shoulders. And then that's usually what I do for children because they haven't grown into their heads yet. Okay, so you can do it under their occiput or under their shoulders, and it kind of gets them in a nice neutral position. All right, want to go? Yes, ma'am.
Was that a new slide?
Oh, if it is, it's not much. There's not much variation, I promise. It should be the same, but if this is the only one that's missing.
Slide 42.
It might have been hidden when I uploaded it somehow, but don't worry. I didn't do a Dr. Bridges, okay? There's no different slides, okay? All right. Okay, moving on. So non-invasive, we already talked about this a little bit. Nasal cannula, high flow nasal cannula. We're gonna put patients on this right away if they need some sort of oxygen support. And this is how much it's being delivered as far as oxygen percentage. Is it still off? It's all good now, right? We're back on track. I think it was just that one slide. Sometimes if it's accidentally hidden, then it won't upload into Canvas, so no worries. Nasal cannula, usually we only put it up to 6 liters per minute, and that delivers oxygen up to 44%. However, I'm going to talk about high flow oxygen in just a moment. Like if I'm about to intubate this guy, I'm going to put him on super high flow nasal cannula. Like I'm going to turn it all the way up to 30 or 40 or however high it goes, plus the non-rebreather or BDM to give them extra oxygenation, which we're going to talk about in a moment. But anyway, you can do simple or non-rebreather masks. They deliver different percentages of oxygen, and that's the point of this slide. Okay, so you can see I have all this stuff set up here, right? It's a lot of stuff. I know it's hard for some of you in the back. You need an airway tray or what we usually have at all the hospitals or an airway box. It's like a little orange box that says airway. It has all this stuff in it. It has all your non-invasive airway stuff. It has a bunch of ET tubes, stylets, bougies, things like that. We're going to talk about all that, and that's important to have. And then separate from that is all your drugs. And so it's nice if you, like if you're in a deployed setting and you have a battalion aid station, you can buy an RSI kit. You can make your own, which is what most of us do, and you have all your drugs right there ready to go. And if you're smart, you'll have a cheat sheet reminding you of the dosing, because we all get sympathetic overload when we're under duress, and we can't calculate things very well. And this is not one time to mess up. Anyway, this is all the equipment that we typically have at our disposal for non-invasive airway management. Okay, the BBM, you guys have learned about these before? Has anybody ever talked to you about this stuff so far in PA school? Not really, right? So we're going to do more of this. We're going to do some hands-on during the EM lab. But a bag valve mask, it should have a little insufflation bag attached to it, and you can use it as a simple mask, you know, and just have the oxygen flowing. Like if this person's breathing spontaneously, you just get a good mask seal, okay? Just holding it here will deliver oxygen. You don't do positive pressure by pushing the bag unless somebody isn't breathing on their own enough, or that you already paralyzed them and need to breathe for them. Otherwise, you don't give them positive pressure, but you can use the mask to deliver high flow oxygen. Does that make sense? With a good bag mask seal. Okay, NPA, have you guys, you said you guys haven't learned this a whole lot, but the nasal pharyngeal airway, I use this a lot in patients that don't have head traumas. You just stick it in, the bevel is towards the septum, and you can measure it from the tip of the mouth to the tip of the earlobe, but that's about the right size. And I was like 0 days old when I learned that this one fits everybody, because you can actually adjust the length of it by that. You can see this, I can use this one on a pediatric patient if I wanted to, but not ideal. But anyway, you measure it from here to here, like so, and then insert it. And so what that is, if the bevel is towards the septum, then that means that the tip of the bevel is away from the septum and less likely to catch Heiselbach's plexus and cause a nosebleed. All right, and whichever nostril is more patent on a particular patient, you can take a quick look in there if you have time. And if somebody has like a deviated septum, I would go to the other side. Does that make sense? Okay, we do this in patients that don't have mid-face trauma, they're still, maybe they need some airway management, like they're maybe a little bit obtunded, but not enough to warrant intubation, or you think that they could decline, so we're gonna do that. They still have a gag reflex though, okay? That's why NPAs are okay. They still have a gag reflex. They should not entice the gag reflex. If you guys start getting wiggly and you need a break, let me know, okay? I'm gonna rely on the class leader to give me the oval when it's time. Okay, this oral pharyngeal airway, the OPA, I usually only use this as a bite block, okay, after I've intubated. I don't like these, I don't use them. They're kind of trash, but sometimes we'll still use them in pediatric patients when we are, not really prepared for what that we're dealing with. So again, you measure from the tip of the mouth to the ear, and you can insert it different ways. We're going to practice this during our airway EMED lab day. All right, we're going to talk briefly about the extraglottics. We have different kinds of extraglottics. These are all considered extraglottics. They're outside of the glottis, which is why they're extraglottic. Okay, this is a supraglottic extraglottic. That means it's above the glottis, but it's still outside the glottis. And this is a retroglottic retroglottic extraglottic airway. Okay, which one of these is better? Yeah, depends on who you talk to, right? I'll tell you that the TC3 committee is pulling all the extraglottic airways out of their guidelines, all right? And I vehemently disagree with them, but I'm not on their committee. The iGel is really nice because it comes with a nice little cradle, and all you do when you insert it is you basically just, when the patient has to be unconscious and not have a gag reflex, right? You're just going to insert it all the way to the back of the mouth till you feel what they call definitive resistance. So you just basically push it in there. And what's nice about that is that it has this little fold here that keeps the epiglottis from folding over on it. It's real soft plastic here, so it seals the back of the mouth, the glottis area. It's got a built-in bite block already, and it's got a couple ports here. One to connect your bag valve mask if you've had to do positive pressure ventilation that attaches to it like so. And if you want to give supplemental oxygen, you can actually attach it to here and give oxygen through the iGel. And then lastly, there's a little port here that you can drop and actually do suction out of the iGel, which is pretty cool. But you have to use the proprietary suction catheter that does not come with the airway device. It's an extra expense, of course, because they're good business folks, right? Okay, that's that one. We'll talk about it briefly. And then we have the King LTs. I'm going to go over it again in just a moment. So we talked about non-invasive positive pressure ventilation or BiPAP. Who gets that? Who gets put on BiPAP? Yeah, they CHFers, they come in with flash pulmonary edema. Who else gets it? COPDers, CHFers, asthmatics. People who are trying to not intubate, right? Not trauma people, typically. Trauma people don't usually get BiPAP. If we have a GCS of less than 8, what are we doing? We're definitely intubating. Okay. All right, so here's ideal patients and don't use, and patients who are altered. So again, most of our trauma patients, it's in here just talking about airway management in general, but we can put people who are septic on BiPAP if they come in a little bit altered. We can't do it. They have to be able to participate in their BiPAP. Okay, It actually reduces the work of breathing by 60%. So this is what we were doing during COVID when everybody was coming in respiratory distress. We try to put them on BiPAP first. We prone them, put them on their bellies, and then we put them on BiPAP. And what that helped is to recruit alveoli and decrease their work of breathing by over 60%. Okay? All right. So here's when we use BiPAP is COPDers, pneumonias, I just told you about COVID patients, asthmatics, people like that, not in trauma. All right? Complications. We've talked about this before, right? Is it okay if I flip over this pretty quickly? We talked about complications of BiPAP. You could, if you have it turned up too high, you could cause some barotrauma. There could be some air trapping. Patient might be uncomfortable, right? Because it's very, if you feel claustrophobic with the mask on. All right. Extraglottic airways, I already told you about the eye gel and how it works. It's pretty nice. I'm going to skip over the eye gel since I talked about it. Complications of eye gel is usually just a sore throat. I will tell you though, if I'm in a pre-hospital setting and I'm using an eye gel, it's hard to keep that thing in place. It has this nice little strap that comes with it, but if you just barely move the patient, it can come out pretty easily because there's no cuff to inflate to help keep it secure. So it comes out easily, so just keep that in mind. Whereas the King LT, which has been around a little bit longer, it actually is a little more secure. I did put this guy, the original extraglottic airways, which are the LMAs. A lot of times people will use this in the hospital, and this is a perfect airway device if you're just taking a patient from the OR to the recovery room, but it's not perfect for downrange use for the same reason. It comes dislodged pretty easily, but I have all these available and you get to play with them all in the EMED lab. Let's talk about the King LTs. Okay, this is a retroglottic airway. Anybody here use a King LT on a patient before? Yeah, I've used them a lot. I love them. This is my backup to my backup. If I fail intubation, I've already sedated and paralyzed somebody, and I don't have video laryngoscopy, this would be my backup. I've never had to do that, but this would be my backup. Okay, you could do rapid sequence airway. It's not as sexy, it's definitely not definitive, but you didn't cut a hole in that person's mouth, in their neck, which is bad. So there's different sizes. This is actually has a cuff that you have to inflate, and it actually comes with a syringe that goes with the device. So for those of you that are familiar with this, just bear with me. And so what's nice is that when you inflate it, it simultaneously inflates both cuffs at the same time. So the way this works, you probably need some lube. That could be the patient's saliva or whatever. And there's different sizes. There's a yellow top for folks that are 4 to 5 feet tall, a red top for people who are 5 to 6 feet tall, and a purple top for your missing link types, people over 6 foot tall. Or if you ever have to deploy with female soldiers from Denmark, definitely go purple, okay? They're really tall, and they're really tall, 6 feet. Anyway, it's height-based. So anyway, the way you insert this is you're just gonna put it all the way in and bury it until basically you're hubbed at the teeth. Then you're gonna inflate the cuff, and a lot of times it'll pull up a little bit, and then you go to ventilate, and that's it. Pretty simple, right? So what happens if I go like this and I'm not actually able to inflate the lungs at all? What if I stick it in, I have the right size tube, I stick it in and I go to and I just feel resistance. Yeah, I don't have to deflate the cuff, I just kind of pull it back a little bit because it's just a little too deep for that patient, and then you just pull it back just a tad, and then you get a better seal, okay? Good stuff, right? All right, so the problem with this airway is it's not definitive, and you can literally only keep it in for about 4 to 6 hours because these cuff pressures are so high. It actually causes ischemia of the posterior oropharynx, and eventually it'll start sloughing, all right? And so at some point, if you're pinned down somewhere and you've intubated somebody with this, and it's been 4 to 6 hours, you're gonna have to start figuring out how to change this into an ET tube. So some people will be like, well, I just take my bougie and I stick it in here, or a stylet, and it goes out that hole and it goes right into the trachea, and that's what it's meant to do. And the answer is, you might get lucky, and you may have to try that if you have no other alternative, but that is not what this is for. So know that. And bougies will cause airway trauma, so be very careful, okay? So, but if you're pinned down, you gotta try something. So you're not wrong for trying, but don't think that this is reliable by any means, because it isn't, okay? All right, anybody been taught that that's how you do that? That's how you mitigate it, or transfer it to a, yeah, I was taught that way too, and it's wrong. But you may get lucky, okay? So if you do it on a mannequin, you're like, see, it does work, got it, you know, but it's not a real person, okay? Do we need a break? Why don't we get through the non-invasive stuff, and then we'll do a break, because I really want to focus on invasive, and that's the gist of this. And I need to inspire you guys to be woken up, okay? All right. Oh, I guess it's perfect timing. Okay. I know it's a quick break. Is it okay to start? Okay. All right, let's get on with the good stuff. It's okay, I barely gave you, like 9.5 minutes. I was a little premature. It's not you, it's me. I say that a lot. Okay. Invasive airway management. So what's the difference? When do we use these extraglottics and NPAs and OPAs? When do we use that versus RSI? Invasive, intubation. When do we do one or the other? So in order to intubate, you usually have to be in a controlled environment, okay? And that could be at your World 2 Battalion Aid Station or on a ship. But more often than not, it's at like a hospital, a combat support hospital, controlled environment with multiple people. We're not out there in a pre-hospital situation with our knees in the dirt trying to pull out a laryngoscope blade, okay? So you need to be in some sort of controlled environment. And I was a rookie. When I first was a brand new PA and we invaded Iraq, I had to intubate a few people, and I'd never done it by myself before. I'd never done an RSI. I had a big Tintinelli in the back of my tracked 577 vehicle, and I was trying to read on it really quick before I actually had to do it, because there wasn't a controlled environment. I mean, the most controlled environment was my little aid station set up out of the back of my 577. So I know I'm dating myself, but probably was not the most ideal situation to intubate in hindsight, but I didn't know what I didn't know. But luckily, I got lucky. And it truly was luck, not skill. So if I can do it, anybody can do it. Okay, anyway, so tell me, what's a crash intubation though? Yeah, it's an emergency. Somebody just went down. Who do we see this happening to mostly? So if we're looking in trauma, it could be from like massive head trauma, but just in general in the population, it's exactly what they said. It's a sudden cardiac death, okay, cardiac arrest. We see all these people, they lose their airway, they're out there doing CPR, right? They're just mostly doing chest compressions. So whenever the first medical folks are in the back of the EMS vehicle, they choose to intubate, they don't have to do RSI. It's a crash intubation. So even though they're in the back of their vehicle's not moving. They're not supposed to intubate while it's moving. And those of you that are EMS paramedics, you know that you're supposed to have a stopped vehicle. So a lot of times they'll do it in the back of their vehicle, but it's not moving, that way they can get the airway. And that's just a quick intubation, crash, all right? They don't need medications, there's no sedatives, no paralytics. The patient is basically dead, does not have a gag reflex, and you're just trying to secure their airway. Now, thinking about that, how many times do you think somebody who's intubated in a crash intubation situation, how many of those people walk out of the hospital completely neurologically intact? What percent? Give me a percent. 5%, 10%, what we got? 2%, less than 1%. That's terrible. So if you just happen to need an airway, a crash intubation situation in a pre-hospital setting, your chances of walking out neurologically intact from that is less than 1%. So the whole premise of RSI, which is rapid sequence induction to facilitate intubation. It doesn't stand for rapid sequence intubation, it's rapid sequence induction. The whole purpose of that and premise is to forecast who's going to crash before they crash so that you increase the odds that the patient's going to walk out neurologically intact. Does that make sense? Did y'all understand it to be like that already? I never knew that, right? And so, anyway, how long can the typical brain go without oxygen? Completely devoid of oxygen. I know we talked about this briefly. 4 or 6 minutes or so, you start seeing irreversible personality changes. After about 10 minutes, there's complete anoxic injury. They're not coming back from that. All right, so you don't have very much time. That's why there's such a bad outcome for people who get crash intubations. Okay, so RSI, rapid sequence induction, is forecasting who needs to be intubated. They have an airway now. I think this person needs to be intubated because of all these medical conditions or whatever. We're going to talk about that. and it's a controlled procedure. So this takes several minutes to accomplish, all right? 4 to 6 minutes probably, at a minimum, is how long it takes. And then you have to have a team of people. What people do I need? It'd be great if you had anesthesia or somebody, but you need a team of people, right? So even if you're the intubationist and you're running the whole thing, who do you need to help you? It'd be nice to have a couple medics or something. You need somebody to be the recorder. You need someone to hand you airway stuff while you're about to do it. You need an IV person, a medication person. What else do you need? Maybe somebody go get other stuff, right? To check all the equipment, all that kind of stuff. You need several people, at least 4 to 5 people to help you, especially if you're the intubationist, all right? So we're gonna talk about that. It's a controlled procedure, and you need 2 classes of medications. You need a sedative followed by a paralytic. Why don't we give a paralytic first? Because you're a freaking animal, inhumane if you do that. Can you imagine being completely aware of being paralyzed, not sedated? That's a very inhumane thing. And there are some hospitals that will pull your credentials on the spot if you do something like that. I had a paramedic that worked for me when I was at Fort Carson. I ran the ambulance services, and there was this guy, and he would do it all the time. He would intubate somebody pre-hospital, and then I would ask, I said, Roy, where's your logs? And no sedative, just paralytic. And I was like, what is your dysfunction? You know, and at first I thought that was an education problem. He also had the highest number of crikes of everybody in the area. I was like, you know, for failed intubations. He was just very aggressive, and I made sure he got fired because something was wrong with him. Like he enjoyed, I don't know, being in control or something. I don't know, and I've never met somebody like that in my life. He was the only one. So anyway, I tell you that because you should never not sedate somebody you're about to paralyze. Never, ever, okay, ever. It's the most inhumane thing you can do, and there's a direct correlation with PTSD and these soldiers who are waking up on the back of a moving helicopter, not sedated, but aware of their injuries and intubation. So if they're not sedated, that means they're also not pain controlled. So very terrible thing, don't do it. All right, so sedative followed by a paralytic. We don't do it the other way around. It's still a controlled procedure, even though it's emergent, all right? It takes a lot of people, and the goal is to facilitate endotracheal intubation without having airway compromise or having the patient aspirate or vomit, okay? You all agree? So what's gonna be your backup to direct laryngoscopy? Okay, direct laryngoscopy, you guys know what that is, that term? That's me or you with a laryngoscope and a blade of some sort. That's direct laryngoscopy. So if this is my primary, what's going to be my backup? So if you're lucky, your primary is a video laryngoscope, but like today, it just goes missing and we don't have one. You have to know both. You guys all need to learn both techniques. Direct laryngoscopy, and you also need to know video laryngoscopy, because the backup to direct is video, and the backup to video is direct. So you have to know both. And then the backup to all of that could be something like a bougie, all right, which we'll talk about in a moment. And the backup to that might be an extraglottic airway. And the backup to that, last ditch, is a crike. Okay, so you definitely try not to do that, all right? So why would we want to do this to somebody? Why would we want to take their airway from them and control it? They can't protect their airway, okay? What are some signs that they can't protect their airway? Wheezing, drooling, they're tripoding, they can't speak, maybe not in full sentences, right? Those are all signs. So impending airway compromise, facial burns, GCS of less than 8, they can't protect their airway, right? Because they're obtunded, all right? So oftentimes it's our anticipated clinical course. Like I told you to associate it, the gentleman I saw in Uvalde the other day who was burned, I wanted to intubate him because his anticipated clinical course was intubation. And once we start giving him fluids, he's going to swell. And in my mind, it was better to secure his airway in a controlled environment before I put him on the bird. And I did fly him. The bird guy even said, hey, you just sitting by ground. And I was like, I'm going to fly him, you know. So you get to, you know, make decisions for your patients. But I would have felt better about intubating him. And had he specifically told me not to intubate, then I probably would have. Not because I'm being aggressive, but because I don't want him to lose his airway, okay? But because I was directed, otherwise I had to follow directions, okay? And still, I could have made the decision, no, on the ground, I want to intubate him. When Air Life got there and they took the gentleman away, they wanted to intubate him too. I said, hey, I get it. I feel where you're at, but they specifically did not want him intubated, so they didn't intubate him either, okay? So anyway, usually it's anticipated clinical course. They're going to go through surgery, they're going to get edema after they're resuscitated with fluids, and we're anticipating they're going to need a secured airway. What you never want to do is place a patient in a can't ventilate, can't intubate situation, all right? A can't ventilate, can't intubate situation. What is that? What does that mean? Somebody who has facial trauma, all right, and you paralyze them, you can't intubate them, and if you can't get the tube in, your backup, besides all the methods I said, you should get a good bag mask seal and be able to at least give them some positive pressure ventilations through a mask. But you can't do that if they have a bunch of facial trauma. So you should not even entertain RSIing somebody with facial trauma or somebody you can't get a good bag mask seal on. Are there people that don't have trauma that are difficult to have a bag mask seal on? You guys ever seen people that have microagnathia? They have like a tiny jaw, like their face just disappears into their neck. Have you ever seen that? What about the Leonidas guys that have a giant beard? Is that from Spartacus? What is that from? The Leonidas guy? 300. Same, but distinctly different. Big beards, those are very difficult to get a good bag mask seal, so you have to be really careful. Those are difficult airways. So these are some things that make you want to just stop and pause and make sure you're making the right decision, okay? All right, and I will share a story. I put a patient in a can't ventilate, can't intubate situation, me and a team of people, but it was still pretty terrible. And for months, I didn't know if the patient, we ended up having to crike him, and for months, I didn't know if maybe emergently he had a brain injury, or we maybe took out the recurrent laryngeal nerve and he could no longer speak. I didn't know for months how his outcome was. And again, very lucky. And I'll share that with you towards the end of the lecture. Anyway, believe it or not, most of the time when we fail to intubate, it's because of patient positioning. So I'll show you that little picture that you guys don't have. I could provide you on it in your Canvas download with a little picture of the 8-year-old in the sniffing position. You want to get your patient nice and neutral. And one of the many times that I missed intubating downrange in front of all of these surgeons, right, is because the patient was halfway down the litter. It's not like I, brought him up. He was perfectly normal, no trauma, but I only missed once, because I only gave myself once, but I missed because he was halfway down the litter. And here I was, I thought I was pretty good. I'd already done over 100 intubations, and I thought I was decent, but I missed because I didn't take that extra 15 seconds to put the patient in the right position. I should have known better, okay? The good news is there was no harm, no foul. I stepped aside and we had CRNAs and all kinds of experienced people to take over for me, but it was humiliating, okay, to not, but sometimes you just don't have your day, right? It wasn't a time for me to prove my ego and say, no, I am competent. I know what I did wrong. Give me another chance. I just stepped away as like, hey, you know what? I should have known better, right? So don't do this. Patient positioning. Also, equipment failure. I'll check this laryngoscope blade 100 times. And when I go to do the intubation, the bolt goes out. Okay, that happens. So you always want to have a backup blade, backup handle at all times. Equipment failure. You can mitigate that, right? Are y'all with me? Okay, this is the most exciting stuff you'll ever learn. At least I think so. It definitely wasn't what you were tested on today. Okay, I'm just kidding. Okay, don't tell Dr. Luck because I'm scared of her. All right. Anyway. So tracheal intubation is the cornerstone of emergency medicine airway management, and you guys will have opportunities to intubate. You may have to be really proactive at phase 2 and say, hey, during my ENT rotation, I want to be in the OR with you and let me intubate. A lot of ENT procedures, they'll do nasotracheal intubations. But if you're on ortho, you're about to do an ortho surgery, hey, anesthesia person in the room, can I go ahead and intubate before I help the surgeon with this ortho case? Just be proactive. Get some intubations under your belt so you can have some confidence. All right. Why do we want to intubate? Well, again, anticipated clinical course, somebody's failing to oxygenate, failing to ventilate. Those are the 3 indications. We're going to do it because it allows a permanent airway for a significant amount of time potentially, right? And allows us to keep the patient sedated and pain controlled as well. All right. So here's the meat of it. 7 Ps of RSI. Have you guys heard of this? The 7 Ps? One of them, the most important one, is paralysis with induction, but it doesn't go in that order. Induction is a synonymous term to sedation, so sedation and induction mean the same thing, but they had to make it start with paralysis so that it came in line with the 7 Ps, but we always sedate first, then paralyze. All right, so we're gonna talk about the first one. So the first one is, hey everybody, this patient is not protecting their airway. Their GCS is less than 8. I believe that we need to intubate. This is what I want everyone to do. Me being the team leader, you, I need 2 large bore IVs. You, please draw up 200 milligrams of ketamine and 100 milligrams of rocuronium. You, can you get one of our record sheets and start keeping time? You, I'd like you to put the nasal cannula on the patient, start doing high flow oxygen, and we'll start pre-oxygenating the patient, also put a non-rebreather. Does anybody disagree with the decision to intubate this patient? You kind of get some buy-in from everybody. You're educating them, you're calm, you're directing traffic, you're telling them what's going to do, you're being very specific with your orders, okay? And you're explaining why you're doing what you're doing. Okay? You need all that same equipment that we had for non-invasive, plus all the stuff that we need for intubation. All right, which is the laryngoscope blade and handle. Okay, does it matter which kind of blade or handle you use? So the handle doesn't matter, it's kind of whatever you get, right? But if you had a choice, there's short ones, thin ones, fat ones, long ones, you know, whatever you either have on hand. The size of the blade matters. This is a 3 Mac, actually this is a 4 Mac. No, it is a 3 Mac, this one has 2 3s in it. Medical Center of Excellence right here, okay. This is a 3 Mac, and this is a Miller blade. This should be a 2, but it looks like it's a 3. Yeah, it's a 3 Miller. So anyway, usually you'll use a 3 Miller or a 3 Mac or a 4 Mac blade. You guys know the difference between your blades? Yeah, we're going to talk about it. I get to teach it to you. All right, we need all that stuff. So we need a laryngoscope, a handle. We need a blade of some sort, which we're going to talk about in a moment. We need an endotracheal tube. And what size tube do we need? So so a burn patient will need an 8, but in most females, let's say, what's a good size for a female patient? 7 to 7.5. Okay, good. And then a male, 7.5 to 8. All right, ideally. And you always want to have a tube a half a size smaller, just in case you can't get it. Okay. All right. You need suction, because all the time, once you sedate them and paralyze them, they'll have secretions. One of the many times I've missed in my life, it's because I didn't have adequate suction. Okay, so you need to have suction turned on, ready to go. You need to have an oxygen source to be able to breathe the patient. Okay, you need to have a confirmation device. What's the gold standard for confirmation? I hate that Colonel, Major Passion taught you guys radiology, right? I promise you it's not a chest X-ray. Okay, I promise you. And I know before him, Colonel Johnston used to teach X-ray. Like that's a way, it is one of many ways, but it's not the gold standard. The gold standard for confirmation is end-tidal CO2, and you as the intubation has seen the tube go between the cords. Now, my colleague, Colonel Gomez and other folks will argue, well, seeing it directly go through the cords isn't the gold standard because students, people who are training, learning airway, they'll lie. They'll say, I saw it go between the cords, because they don't know what they don't know. And so they'll think they saw it go between the cords, but they didn't. So the American Heart Association is saying, okay, we can't rely on anybody who's a provider to say whether it went through the cords or not. So end-tidal is the way to go. But it takes a while for end-tidal. And even at BAMC, I've intubated in their trauma bay, and they haven't even had end-tidal set up. So end-tidal is the gold standard as far as the book answer goes. But in real life, you need to see the tube go between the cords if you're the person intubating. Does that make sense? And you also need to confirm by 3 different methods. So we're going to talk about all that. Okay? Do I have you with me? All right, so what am I going to do to start preparing? I just told you I'm assigning jobs, but how are we going to prepare? What do we need to do right before we do it? We're going to pre-oxygenate. That's the second P, which we're going to get to in a moment. But in my preparation, besides telling people what to do, I'm going to do exactly what I've been doing up here. Recheck all my equipment. I'm going to look at their airways, see about the size. I'm going to make sure all my cuffs work when I inflate. Oh, this one kind of sucks. Let's get a different tube. You know, that's the kind of stuff you need to do. That's why I have an extra tube up here, because I'm at the Medical Center of Excellence, and I knew that might not work. Okay. So you're going to be checking all your stuff, making sure everything works, getting everything set up. All right, that's preparation. You want to make sure you have 2 large bore IV accesses, right? Because 2 is 1 and 1 is none. and you're gonna stay calm. Can you imagine if I'm up here freaking out and you're helping me, all that energy, you're gonna feel it, right? I'm freaking out, you freak out? No? Maybe? No? Okay, I would. I would take a little extra time to make sure the patient's in the appropriate position. So first one is suboptimal, that first picture, right? Do you guys agree that he's like all bent over? Do you think you can see the airway really well? Yeah. Unfortunately, downrange when your patient's on a litter, they don't have adjustable beds, right? But in a hospital setting, you do. You can pump that thing up, you can make it go down, you can move them, left, right, whatever. So get them in a good position. You want to make sure your oxygen's functional and turned on. You want to make sure all the stuff is ready to go. And I'm going to tell you, everybody, hey, my primary is I'm going to use direct laryngoscopy for intubation. My backup is video laryngoscopy. My backup to that is going to be an extraglottic device, and I also have a cry kit here should all of those fail. Does that make sense? You want to make sure it's really clear and the plan is right. You kind of want to guesstimate a patient's weight. What's the average weight of an adult patient, which they usually reference males? What's a usual adult average weight? About 70 to 80 kilograms. So, what I usually do, especially in trauma, is I round up. Everybody's 100 kilograms, right? Is that bad that I do that? Are you just going to make them more sedated and more paralyzed? Does that matter? In trauma, not so much, but in medical patients, it might. Like if somebody's septic, you might want to go half sedative dose, all right? Because you're going to really take their pressures. But in trauma, you can round up and keep your mouth simple, okay? And we're going to talk about that. You want to have all your stuff readily available, and then assess the airway, okay? What's going to tell me or give me trouble with this airway? Is this patient obese? Are they a workout? Anybody know Major Castelline? Okay, I mean, he's got a head and he's got shoulders, okay? And I can say this because he's my friend, right? I don't know what happened to his neck, okay? But he's really muscular, I think. That's what happened. And so he might be a difficult airway, okay? Don't tell him that, but it could, okay? It happens. Or people with small chins or big beards. Those are all difficult airways, all right? We also want to take a quick look in and see what we're dealing with. There's classes 1 through 4. Class 1 is you can park a truck in there, okay? Class 4 is you can't even see anything. Does that make sense? Have you ever seen a patient, you guys don't have much patient care experience, some of you do, but some patients, you'll have them, they'll come in with sore throat, and you're like, open up and say, ah, and you're like, yeah. And they don't show you anything. And I'm like, what? They're not even a trauma patient, like, and they can't even show you their tonsils. Like, some people just have something wrong with them, and they didn't know that they had something wrong with them. But anyway, you're class 4, so you want to anticipate this because it might alter the way you deal with their airway management. All right, equipment. So you need a blade. Now, ideally in trauma, they have video laryngoscopes, also known as DL. All right, this is DL, and then there's VL. And I told you the backup to one is the other. In trauma bays, a lot of times in trauma patients, they want you to use video laryngoscopy. So at University Hospital here and at Vancy, they have a huge TV screen, and everybody is there watching you intubate. The last few times I've been in the trauma bay, they actually haven't had it hooked up. All they had is the vital signs, which is nice, because it's so unnerving when everyone's like armchair quarterbacking you, and you're trying to, some guy in the back who probably hasn't intubated in 20 years, like, go left, go right. You're like, my left, your left. I don't know, it gets confusing. But anyway, you want to do video laryngoscopy because if they have a C-spine injury or something else, you don't have to move them much if it's a video laryngoscopy. If it's direct laryngoscopy, after I've done the tube and stuff, I'll actually grab the patient's head and I'll move them around, whatever I need so I can see that. Okay, but obviously if you think that there's a C-spine injury, we don't want to do that. So we'll do something like video laryngoscopy if you have that option. But there's different types of blades, and we're going to talk about this too during the airway lecture during the EMED lab. This is curved. It's called a Macintosh blade. It's curved like a Macintosh apple. And the benefit of this is what I would use on one of you, a 3 or 4 Mac. One of you, non-difficult airway, what happens is you put it in and it lifts up the epiglottis indirectly. This little tip fits in something called the vallecula, which is a ligament, and it indirectly lifts up the epiglottis. Versus a pediatric patient, I want to use a Miller blade, which is straight like the letter L, like Miller. Okay, that's how I remember them. The reason why I want to use the Miller is because they have floppy epiglottises. And what you want to do is this directly lifts that up. So it actually grabs that epiglottis flap and lifts it up directly. And I'll show you what I mean in just a moment. So there's benefits to knowing both. I used to be a 3 MAC person, and then I missed a few, and then I'm like, okay, there's times where I need a Miller. And so, especially if they're having difficult airways. Do we need another break? Because I'm doing great. I don't need a break. Okay, let's keep going. Okay, we talked about ET tube sizes, females 7, 7.5, males 7.5 to 8. Burn victims, you want an 8 so they can do the bronchoscopies. And then you need a way to secure the device. Now, in the hospital, there's these cool little ET tube holders that fit around the device, and they Velcro, and that's really nice when you're in a controlled hospital setting. But if you're in, like, somewhere in the desert, what does Velcro not like? Sand, body fluid, saliva, blood, all the stuff you're probably knee-deep in, okay? So you're gonna have another method. I use 2-inch tape or 1-inch tape, whatever you got, and this is just a tongue blade. And what I usually do right before, if I have the time, I'll take 15 seconds or so, and I'll kind of walk this blade around, and this is how I like to use my airway to secure it around the ET tube. And I'll show you guys this. So I load the tongue blade up like so, and then when it's time to, after I've intubated the patient, when it's time to secure the device, because everybody wants to pull your tube out after you've just worked really hard and got it in perfectly. This helps you walk it around the patient's neck and stuff. As you get it started, it helps you walk it around the neck pretty easily. And I'll show you this during the airway lab as well. Okay. Anyway, you need a 10 cc syringe. Why do I need a 10 cc syringe? Yeah, because there's a cuff here. Only 10 cc's. Don't do more because you'll break your cuff. You do want to test it right before, and then you want to suck it all completely out so it's nice and flat. You need lubricant. All right, you need to put some surgical lube right on here on the cuff, not here at the tip, but here at the cuff, and you want to make sure you don't do too much because then you won't be able to see what you're doing. What needs to be inside this tube? I can use a bougie, which is this thing, if you're fancy, okay? As a joke, okay? Or a stylet, which is what I like, and this is how it comes out when it's brand new, is a stylet. I like to do a gentle kind of hockey, you can do a gentle C curve, or you can do a hockey puck like on it. That's how I like to do it. I do the hockey puck. Some people, like the anesthesia people, they like to do a gentle C. I hockey puck it because it is more likely to find the trachea. Like if you can only see the epiglottis, it'll guide you anterior. Or you can do a gentle C, either way. So a little hockey puck, and to give you some form. Or the bougie actually has that little anterior hockey puck already for you. So just make sure you use that end and not the other if you're going to do it. Some people, like Colonel Gendron, whenever he has to intubate, he always just uses the bougie every single time. He has this in here like so. I don't do that. That's just my personal preference. I like the bougie for difficult airways if you can't see the cords. But I like to put the bougie in first and then just thread the tube over. The bougie can cause a lot of airway damage, so if you're not careful. And so can the stylet if you allow the stylet to stick out the bottom of the tube. So you never do that. That's why this is malleable at the top. You can actually adjust it so it doesn't go beyond the tip of your tube. Everybody with me? All right, I know this is hard. We're doing a marathon today, but you're going to get a reward for Friday. Get your weekend, okay? All right. We talked about all these things, and then IV tubing. What's IV tubing? Do I need IV tubing? Do I use IV tubing for something besides the IV? You can actually, if you had to, you can actually tie it around your ET tube and use that to secure your ET tube, and that rubber on rubber friction actually holds the tube in place. All right, so we got through step 1. That felt really long. You guys agree? The rest of them will go quicker. We talked about pre-oxygenation. So what is pre-oxygenation? As soon as I said, hey everyone, we're going to intubate this patient, I put them on a nasal cannula. I can put them on a non-rebreather or just have the oxygen go through the BVM and just hold a nice seal. We're going to pre-oxygenate, and I want you to know that we have to do it for at least 3 minutes. All right, and our perfect situation is 3 minutes, or in a pinch, 8 vital capacity breaths. What does that mean? What's a vital capacity breath? Very deep. He just demonstrated it. Very deep, like a sigh. That's a vital capacity. Most of the time we're just sitting here breathing. We're just barely kind of moving a little bit of air. A vital capacity breath is a full breath, like a big sigh. So we need 8 of those in order to pre-oxygenate. But what's the purpose of pre-oxygenating? What am I doing? What are you doing? Yeah, you're increasing the patient's residual capacity in the lungs. You're basically replacing all those other gases like nitrogen with 100% oxygen. So you're buying yourself more what's called safe apnea time. So after you've sedated and paralyzed the patient and their diaphragms aren't moving, you've just bought yourself several more minutes of time to get that tube in a controlled environment. Does that make sense? So did I tell y'all that I got picked to do a study one time? They asked me if I would, there was one of two choices. Did I want to drink alcohol and see the effects of alcohol on my body over time, and they would provide the alcohol, or did I want to be in the arm of people that they gave a pre-oxygenated, sedated them and paralyzed them, and then see how long they went before they desaturated? Which one do you think, I mean, anybody logical would choose? Definitely the alcohol one, right? And they paid me for that. I was like 18 or something. But I was like, who would want to volunteer to be paralyzed and see when they, but some people did, and the average person, non-injured, actually went 8 to 10 minutes after appropriate pre-oxygenation before they actually desaturated. So their safe apnea time on somebody not injured, healthy, no comorbidities was about 8 to 10 minutes, all right? How long do you think the desaturation time is for a trauma patient? Yeah, definitely less, a lot less. The metabolism is different, their heart rate's different, right? They're gonna metabolize the drugs differently. Insert pregnant woman, child, older person with comorbidities, all their safe apnea time is gonna vary. So it's really important that you try to buy yourself a little extra time, and maybe all that pre-oxygenation only bought you 30 extra seconds, but it's still 30 extra seconds. All right, so I want you to pay attention to this oxygen dissociation curve. I'm just kidding, okay? What I want you to look at, okay? I was gonna talk about the chemistry and pathophysicists, but it's boring. So what I want you to do though, this is a chart, and it's time to desaturation with initial oxygen, almost 88%, okay? So before they gave them supplemental oxygen, it got them up to 100. And so what I want you to pay attention to on this chart is it doesn't matter if you're an obese adult, a normal adult, ill adult, whatever, normal child or adult. This is saturation, and this is time in minutes. So whenever anybody gets to about 90%, their oxygen levels start at close to 100, they drop to 90, everybody falls off the curve after that. So I use that when I'm intubating. I say, hey, monitor person, look at the saturations and let me know if it ever falls below 90%. What I don't want is some nurse calling out 94, 94, 94. I'm like, you know, that's just too much, right? But I do want to know if it ever drops below 90, okay? Because that's my time to stop what I'm doing, bag the patient back up to 100 ideally, and then start again. Does that make sense? You guys agree that's what the chart shows? Everybody kind of falls off that once they get to 90, it's a pretty abrupt climb to the bottom of desaturation. And the one gentleman I told you about that we put in a can't intubate, can't ventilate situation, his stats dropped into the 40s. Okay, very terrible, okay? And I wasn't in control of the airway, but it doesn't matter. I was still partaking in it. Very terrible situation. So, all right, we got through pre-oxygenation. How long do we do it?
3 minutes.
Or? Very good. Okay. All right, and we're creating a functional residual capacity of oxygen in the lungs. You guys need another break? We're okay? Okay. All right, pre-treatment. If it's okay with you, I'd like to just eliminate this. Okay? No pre-treatment. Back in the day, we used to give a little drug to counteract another drug, and then, oh, if they had a brain injury, you might want to add some lidocaine, or if they had a heart attack, you might want to add some fentanyl, and that just got really confusing and clogged up the whole RSI picture. So if y'all are okay, let's just skip this. This is like the 6-minute abs instead of the 8-minute abs. Okay, I guess it'd be 7 minutes, no, 6 out of 7, okay? So we're just gonna eliminate that step. So let's jump to the most important thing of this entire lecture, all right? The most important concepts are right here. It's the paralysis after the sedation or induction, okay? So we have 3 sedative agents. The ones in red are the TC3 drugs of choice, and actually what we use more often than anything else in the emergency department, especially for trauma patients, all right? The 3 sedatives that you'll need to learn about a little bit is ketamine, or are ketamine, etomidate, and propofol. Ketamine's in red because it's the sedative of choice. What do we know about ketamine, and why is it the sedative of choice? What's that? Okay, it's a pretty safe drug, right? I mean, it's got a bad rap, right? It's been on the streets, it was used as a date rape drug, right? But in the right setting, they've actually used it since the Vietnam War on war casualties, and people do really well with it. I love giving my patients ketamine. I love it. I've never had it myself, but it works so well on my patients, whether I just want to give them a little low sub-dissociative pain dose for pain, or if I want to sedate them for intubation or a procedure, it's perfect. It's a great drug, okay? So ketamine, the other good thing about ketamine, there's a couple other benefits. Anybody else know? Go ahead.
Dissociation.
Okay, it dissociates them, right? So not only does it sedate them, but it dissociates them, right? So they're not aware of what's going on. They're sedated, but they're also not aware. So I'd like to not remember being intubated because that's a pretty traumatic experience. What's another benefit of ketamine? Go ahead.
Increases respiratory side.
Yeah, so it actually increases, it actually causes bronchodilation. So it's really good in the asthmatic patient if you have to intubate, if you use ketamine. Okay, it also increases blood pressure, increases heart rate, which is really nice in our trauma patients, right? Because all the other agents can decrease blood pressure. So in trauma, this is the only one that's going to squeeze and clamp down and increase the pressure. All right. Plus, there's another benefit. What's that? They used to think it increases ICP, but it really doesn't. They used to think it does because it increases blood pressure, but you actually need to increase blood pressure to compensate for increased ICP. So it's actually preferred in patients that have a head injury. So that's a good point. I'm glad you brought that up.
It's difficult to overdose.
It's difficult to overdose. It's a really safe drug, except for when it's been used as a date rape drug. It's also an analgesic. Okay, it treats their trauma pain as well. So that's pretty cool, right? There's all these things. I probably wouldn't use it on an old person that's coming in and it's a hypertensive emergency, but other than that, I use it on pretty much everybody else. All right. Etomidate, we have to have some other agent. In the military, etomidate is your backup. The reason why we don't use etomidate more, and etomidate's a great drug. During my initial trip to Iraq, I had more etomidate than anything, so I had to use it quite a bit. But etomidate's a great drug. It's a sedative, but it's not an analgesic. All right, so you already have to add another drug to your regimen if you're going to treat their traumatic pain, and it's a one and done drug. You can't keep them on etomidate. You just do it once, and then you have to keep them sedated with something else. So it just makes your whole RSI picture a little more difficult. So if I have my druthers, and I use ketamine all the time because you can give it to them, knock them out, sedate, paralyze, intubate, and then keep them sedated with more ketamine. It's really good stuff. Etomidate, one, and now you got to add morphine for pain or fentanyl. Then you got to add something else to keep them sedated. Propofol's on here. We use it in the ER, and a lot of ERs like it. Why don't we use it in the military? What's that?
You gotta keep cool.
Yeah, it's temperature dependent. It's like that white milky stuff. It's fat and emulsed, and so it'll completely, whatever, emulsify if it's not kept at a regular temperature. What's another reason why we don't like it in trauma? It causes hypotension. Okay, so we don't do that. It's just bad in trauma patients to cause hypotension. All right. So those are your three sedatives. Ketamine's a sedative of choice. We have three options for paralytics. All right. The TC3 drug of choice is rocuronium, and that's what we use most of the time in the ER. Why do we use that over succinylcholine? Yeah, it's just a little safer, all right? But I use succinylcholine on so many patients, and I've never had a bad outcome. It's a good drug. You just have to be aware if you choose succinylcholine, it's the only short-acting paralytic. Short-acting means it's going to wear off in 6 to 10 minutes, all right? That's kind of a good thing. You don't need your patient to be prolonged paralyzed. You need them to be prolonged sedated. And so that succinylcholine is a perfectly fine drug as long as you know when not to use it. Do you all know some contraindications to succinylcholine? Burns. You can use acute burns. Like the other day, the gentleman, I could have intubated him with succinylcholine. That's fine. But if he had been out in West Texas and it took him 3 days to come in, 3 days up to 6 months post-burn, post-crush, post any major injury like that, you cannot use succinylcholine because of hyperkalemia. It'll cause hyperkalemia. What does hyperkalemia do to the heart? It makes it stop. Okay, so it's bad. All right, so let's move on. So succinylcholine is the only short-acting. Roc and Vec are long-acting paralytics. We usually prefer rocuronium because it's safer. Vec is a powdered formula, so this is what I had during one of my trips to Iraq. It's nice because you can carry it around and then just you put a little saline in there and mix it up and it's ready to go. You just kind of get the powder dissolved and it's ready to go. So that's what we had to use. But rocuronium is better. So dosing. I'm only going to ask you a little bit about dosing, but you don't have to memorize all this, okay? I'm going to tell you what you need to know. All right, I would know ketamine dosing, and I would know rocuronium. And I'm going to tell you right now, it's 200 ketamine, 100 rock, assuming somebody weighs 100 kilograms. I'm sorry, 100 pounds. No, I'm sorry, 100 kilos. I'm sorry. I'm getting myself confused. I'm trying to go fast, and I always round up in trauma, okay? And it just keeps the math simple. If you want to be real accurate, you can calculate the patient's weight and do specific mgs per kg. Ketamine is 2 mgs per kg, is safest, and rock is 1 mg per kg. So however you want to know that, I would know it. Etomidate, you don't have to remember, but it's 0.3 mgs per kg, and it usually comes in a 20 milligram vial. And so I would usually give the entire 20 milligram vial to an adult. Propofol, I'm not going to ask you to remember at all. Remember that ketamine has multiple benefits, and that's why we like it. Now, is anybody worried about the emergence phenomenon that happens with ketamine sedation? Are you worried about that when we sedate and paralyze for intubation? No, we're not, because we're going to keep them down, okay? They're going to stay sedated. So once ketamine wears off at about the same time sectional choline, 10 minutes or so. We used to think it's a long-acting drug, but it's not. So you're going to give ketamine 200, followed by 100 milligrams of rock. You're going to wait for those two medicines to work synergistically together to create perfect conditions for intubation, then you're going to intubate. All right? So why is it called rapid sequence induction? What's the rapid sequence? Is that you're rapidly throwing the tube in there? No, it's the rapid sequencing of those drugs. So what you're going to do is, okay, everybody ready? We're about to go ahead and push medications. I want 200 milligrams of ketamine and 100 milligrams of rocuronium, okay? And so go ahead and push the ketamine. You're going to push it in over about 10 seconds or so, 15, not super rapid, but not slow. Followed by a flush, then paralytic, flush. The rapid sequence is drug, flush, drug, flush. That's why it's called rapid sequence induction. And then you wait. You wait a minute, because that's how long it takes for rocuronium, up to 2 minutes for it to kick in. And so you're waiting, and you're looking at the time, or if you have somebody keeping time, your recorder's like, okay, it's been 30 seconds. And you're looking at the patient waiting to see that jaw relax. You're going to check their corneal reflexes. But that's a time for you to sigh, take a deep breath, make sure the patient's in a good position. That's my Zen time. I've got to stay calm so that I can get this airway. And then once you know that paralytic is kicked in and the sedative together, it's time to intubate. Everybody with me? Okay. We're going to maintain sedation afterwards, but that's post-intubation management. How many mgs per kg is ketamine? 2 is better. It says 1 to 2, but 2 is better, okay? How many mgs per kg is rock? 1, very good. So 200, 100, that's pretty easy. Now, sectional choline is the same dosing as ketamine, and it lasts about the same time. So if you're an inexperienced intubationist, there's no contraindications to sectional choline. In a perfect world, you would sedate them with ketamine and paralyze them with sectional choline. Similar doses, 200 of ketamine, 200 of sectional choline, same dosing, okay, and same duration of action. Why would that be more beneficial than rocuronium that lasts 45 minutes? Why would? That's right, because you have to remember, you have to redose your sedative. But they won't tell you that you have to redose your sedative if you knocked them out with rocuronium, which is going to last 30 minutes longer than your ketamine. So you're about to set yourself up, if you're not careful, in the same scenario as just intubating with a paralytic alone and not a sedative. Does that make sense? So it's very important, if you choose to use rocuronium, that once you've intubated, secured your tube, confirmed confirmation by 3 different methods, once that's all done, you should be thinking sedation, 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 because your patient should never wake up from sedation, okay? But if you use ketamine and then sectional choline, and the patient starts bucking around and chewing on their tube, it reminds you, uh-oh, I need to sedate them more. Especially if they go like this and pull the tube out, okay, then you're like, I should have sedated them more. But if you give them rocuronium and you knock them out, they're not going to remind you to sedate them. And that's a really important concept, because the only way that you'll know that they're coming light out of their sedation, as their blood pressure might come up a little bit, or the heart rate, or there might be like a tear coming out of this corner of their eye. It's really terrible, okay? So I just want to emphasize that you need to take sedation, sedation, sedation. Do you have to re-paralyze them? You shouldn't have to, all right? You should only sedate them, paralyze them once, then keep them sedated. Now this is different. In a hospital, you might see during your rotations, you go and do some sort of surgery rotation or whatever. The anesthesiologists that have the cool little tin syringes and they've got like stuffed animals hanging off with their stethoscope and stuff. Maybe that's just in the PD wards, but they can just sedate somebody deeply and never paralyze them and get an airway. And that's fine, they're in a hospital, all right? Don't do that with trauma patients, you're sedating and paralyzing, okay? These are important concepts, and I know I'm being very passionate about it, and you guys are just like, please get me out of this verbal chokehold, I just want to move on with my life. But this is really important stuff for like the rest of your career, okay? And again, I'm projecting my traumas onto you, okay? And that's what really this is about. Okay, just kidding. All right, so what did I say is contraindications to succinylcholine? Burns, crush, 3 days to 6 months. Also, you don't want to use it on anybody with a neuromuscular disorder, like Guillain-Barré, or you suspect Guillain-Barré, or if they roll in a wheelchair and they go into cardiac arrest, probably would not use succinylcholine on that person. All those people are prone to hyperkalemia, and we talked about it. And I'll tell you, and I'm not going to tell you a bunch of stories, but it helps, if you associate it with something, it helps you remember. Okay, so one of my colleagues during the EMED residency, they saw a motorcycle accident. A guy had a high C-spine injury. He was also burned. He was treated like a burn patient from all the abrasions from the asphalt, right? And so he was intubated, sedated on the burn ward, being treated just like a burn. Two weeks or so went by. They decided it's time to start extubating him. They did a little trial. He did really well. Extubated him. They checked his labs and everything first. Extubated him. He was doing fine. And all of a sudden he started having respiratory distress, so they had to re-intubate him. They'd already checked his chemistry. His potassium was fine. They knew to look, but they still used a sedative and then used succinylcholine as their paralytic. Now he was paralyzed. Okay, he had a high C-spine injury, so he immediately went into cardiac arrest because succinylcholine is a depolarizing agent, and so at the muscular ends it's releasing potassium. Okay, and so when you're paralyzed, you have no way to counteract that, and he became acutely hyperkalemic and he coded. And so they had to reverse the code, and then, luckily succinylcholine wears off, but the hyperkalemia doesn't. So anyway, so that helps you associate. Don't use it 3 days to 6 months, post-crush, burn, paralysis, neuromuscular problem. Okay, moving on. There's also something called malignant hyperthermia that you'll never know who's going to get that. You're just supposed to have the antidote, which is dantrolene. I've never seen it, and all the times I've used it, but supposedly it's a bad deal. Okay, so we got through sedation and paralysis. Now, during that time, as those two drugs are kicking in and working synergistically, I'm going to make sure my patient's nice in position. I'm going to check my equipment one last time. I'm using a millimeter. This guy is really hard to intubate, okay? I'm going to make sure I have my tube. I have a perfect assistant here that's going to hand me my tube perfectly, and I'm never going to take my eyes off the cords. So how do I open the patient's mouth? Like, is there a technique that I can employ? Yeah, so I got the patient here, and what they want you to do is a little scissor technique, okay? It's basically you can use your index finger and thumb, or your middle finger and thumb, because I'm not as strong as some of you guys and I have smaller hands. But what you basically do is you're going to put your thumb towards their bottom lip and teeth, and you're actually going to do counteraction like that and open up their mouth. So once you see that the paralytic is working, you've kept good time hack, check their corneal reflexes, they're relaxed, diaphragm's not moving, it's time to intubate. I'm going to open up my blade. How do you hold your blade? Does it matter? Try to hold it with a kung fu grip. It should be nice and loose in your hand, relaxed, okay? And I'm not using wrist action at all, okay? And I'm going to be like those old Rock'em Sock'em robots. You guys ever see those? You guys had cooler toys than I did, okay? And it had like a non-articulating wrist or whatever. But anyway, when you put this in the mouth, after you do the scissor technique, you're going to sweep the blade from the patient's right, which is also your right, because you're at the head of the bed. You're going to sweep it from right to left, and you're going to do a lifting technique towards the opposite ceiling with about 10 pounds of pressure of lift force. If you're doing direct laryngoscopy, 10 pounds, that's a lot, right? So you got to be, and you'll know when you guys do this lab, that these medicines are difficult. You want to not hear him, the teeth break, because it will. Let me see if I can well, this guy's not clicking. So anyway, once you get your eyes on the cord, you don't want to take them off. Hopefully you have nice lube on here. As soon as you see the cords, you're going to stick the tube through. This would have been so much funner to demo if I had a glide scope. Then you're going to have the Kung Fu grip on your ET tube. Inflate the cuff. You're going to take out the stylet. Now we're going to confirm by multiple methods, all right? What's the best way to confirm if you're the intubationist? Direct, yeah, you watch the tube go between the cords, and we used to have to talk to each other. We used to have to say, I see epiglottis, I see cords. Even if we didn't, we lied. We said, I see cords, I'm in the cords. No, you're supposed to tell the truth. This is one time you have to tell the truth. You should always tell the truth, but you definitely need to then. But now when you have video laryngoscopy, everybody sees what you're doing, and that's why we like to use it in trauma so we don't miss. And all trauma centers are teaching hospitals, so that is why. So we want to confirm by direct visualization, but what's the gold standard? End-tidal CO2. This is a colorimetric device. This thing changes from purple, which means poor, to yellow, which means yes, okay? But it takes about 5 or 6 breaths to do it. And if the patient has vomitus in the airway, it'll mess up. This is just a piece of pH paper, okay? Or if they're in cardiac arrest, it may never change to yellow. It'll be like different shades of brown and stuff because they have to have a CO2 of at least 15 in order to change this. This is a colorimetric. This is not end-tidal CO2. End-tidal CO2 is that nice capnographic waveform. So if you have that, you should have it on the patient. And it comes with the nasal cannula, which is great. This is why I like to use nasal cannula for my pre-oxygenation plus a non-rebreather. The nasal cannula has the end-tidal CO2 detector in it. The other thing is I have the nasal cannula blasting at like 30 cc's, okay, really high, okay, just blasting. And the reason for that is even after you've sedated and paralyzed the patient, that high oxygen, even though the diaphragm's not moving, it's going to travel through the airway and passively be absorbed in the lungs. So you're buying yourself even more time by doing that. And I need all the time I can get during this time. I'd rather have way too much time. The stats never drop. That's perfect. So anyway, we're gonna confirm by multiple methods. End-tidal CO2, we see the capnograph waveform. What's some other methods? I heard we're gonna auscultate. We always auscultate, right? You're gonna hear belly first, then right lung, left lung. Why is the belly first? Or you can do left and then right. It doesn't matter, but you have to do the belly first. Why is that? Yeah, because this is gonna go through the path of least resistance. It's gonna be really easy to intubate the esophagus. And every time I squeeze 400, 500, 600 cc's of air into the stomach, it's going to insufflate the stomach and they're going to vomit. All right, so each breath is bad to do into the stomach. So you want to know right away. So you're going to auscultate over as you're bagging, and once they bag, you'll hear gurgling sounds in the stomach, knowing that you're in there. You actually see the air going in the stomach. And how do I know that? Because I've done it before. Okay. Oops, I missed. Okay. I've made it more than I missed. Okay, I'm just humbly telling you that it's okay. Nobody's perfect. So anyway, we got end-tidal. We saw the tube go between the cords. We have a colorimetric device. We auscultate. What are some other methods that we can do to confirm? What's that? Yeah, you could do chest rise and fall. Chest X-ray is another thing, and then they play the game about where the ET tube is. What else? What's that?
The bulb.
Okay, there is a bulb technique. I don't have one here at the Medical Center of Excellence. What else? This mannequin has a torn. I just want you to know when you guys intubate him in a few days or next week or whatever it is, his airway is torn. So they weren't supposed to bring you this one. But anyway, what else? Fogging, misting of the tube. Okay. Okay, and you can actually see rise and fall of the chest. All right.
Feel the warmth from the lungs.
Okay, you can actually feel the breath. Okay, perfect. Anything else? Just remember you have to do at least 3, and 2 of the 3 should be visualization and end-tidal. Okay, the other could be auscultation or whatever. We can even do it by ultrasound, which I'll show you in just a moment. So what's happening when we intubate? In order for us to see the cords, it's like the alignment of the planets. We have to have the oral, pharyngeal, and laryngeal axes all aligned perfectly, which is why patient positioning is important. And I shared with a student earlier, sometimes when I'm intubating, if I can't see, and I don't think they have a massive C-spine injury, I'll actually, if I can't see anything, I'll be like, look, I'll start grabbing the patient's head, and I'll start moving the patient around like this until I can see, okay, as long as I don't break their teeth. And then, which I've never done, but I'll do that, or sometimes I'll say, hey, I need a hand, and I'll have somebody pull the airway one way or the other. It's called the burp method. What's out is cricotid pressure. Nobody does cricotid pressure. It doesn't work. Don't do it. It obscures your view. That's not what I'm having somebody do. I don't like anybody touching my airway. I don't want any help from anybody. I'll figure it out myself. But I will take my hand under the occiput and move it around until I can see. And then what do I do once I can see? I gotta let go, right? I grab the tube. You've got a lot of eager bodies wanting to help you. So go, hey, come over here and put your hands right here and move, keep the patient just like that. And so you want to have them in that position. Okay, so we talked about placing it with proof. We have 3 methods or more to confirm. My kid is hammer calling me, okay? She's gonna be like a big stalker, I think. She needs calls and calls. Anyway, she's off today. You know, I had all the spring break and now kids off. Anybody else here in the classroom have a kid that's off after already being off? Stupid. All right. If you're the intubationist and you're not sure if the tube went between the cords or not, when in doubt, you take it out. Don't err on the side that I think I'm in, you know, and then wait for confirmation. If you have a moment and they're not desaturating, go ahead and take another moment to do it again. Confirm placement. Gold standard is what? End-tidal CO2. The best way is to visualize it if you're the intubationist, that everybody's going to ask you the gold standard, which is end-tidal CO2, all right? Here's all the other ways. We can do ultrasound confirmation too. This is what it should look like when you're looking back there, and you have to have good knowledge of the anatomy to see what you're looking at. And it gets obscured with all their saliva, with vomitus, with blood, with broken teeth. I mean, it really is difficult at times, so keep that in mind. But this is what it should look like. So not this, that's esophagus. This, and this is that epiglottis I was telling you about. So if you're using a Mac blade, it's fitting in right here and you're lifting indirectly, that Miller blade goes right in here and lifts directly. Does that make sense? Okay, everybody with me? We're almost done, okay? We're almost done. This is a long time for both of us, all right? If you think you've been back there, stop. Why is it so easy for a tube to go back there? What's that? Yeah, there's no protection of it, right? You guys eat, some of y'all eat big pieces of meat, steak or whatever, everything goes down back there, right? So not here, the epiglottis will block it for good reason. Okay, so we're gonna measure the CO2. Remember, clear capnographic waveform, and what should the CO2 be at in a perfect world? I know some of you guys give me those looks. I was talking about food and stuff, okay? I saw you, huh? Yeah, 35 to 45 ideally. Sometimes trauma patients have a different displayed numbers, right? But 35 to 45 is normal. It should be over 30. What if they're in cardiac arrest? What might it be? 10, right? If you're doing good compressions. And then if all of a sudden it goes from 10 to 30, guess what? You just got ROSC. Okay, so that's pretty cool. You can actually tell. And then alternatively, when you guys do your ATM lab, and we have these with the Cape burns, you'll see they'll go from like entitled 45 to like 15. So what does that mean? The opposite of ROSC, they just went into cardiac arrest. So it's a really important thing. You can tell if they have a continuous airway or if they just gone into cardiac arrest by their CO2 levels. All right. You can do ultrasound confirmation. You know, I love ultrasound, but I don't do this. There's so many other better ways, but some ultrasound geek decided this was a good thing. And so you can actually put the ultrasound probe right on, using the linear one, right over the trachea. And if you see a double bubble sign, like here, that means your tube is in the esophagus. If you only see one, that means the tube is in the trachea. So double bubble is bad, single is good. That means you're in, okay? That's just another way to confirm placement. And this is a little video of that. We're almost done because we're gonna cover cric in the lab portion, all right? Anyway, did you guys see the video? What do you guys think? What's the consensus? Are we double bubbling it, or it's kind of hard to see, huh? I think you with the light on. Bubble. It's a double bubble. This is bad. Okay, so post-intubation management. So you got your tube in. You confirm placement by 3 ways. We're going to secure our tube with whatever method. Okay, and by the time we do all that, your sedative's about to wear off, okay? Also, we're gonna try to place, after we've done our confirmatory breaths, right, 4 or 5, making sure we're in the right spot, making sure the colorimetric or whatever changes, or you see that end title, we gotta put them on a ventilator. Some of the times we have these like ventilators that are difficult to use, like the Hamilton, that it's like quantum physics ventilators versus this, which is just the Save 2 ventilator, which all you have to do is put in the patient's height and it will calculate its tidal volume for you and do it. So it defaults to 15 breaths per minute. It'll calculate your tidal volume for you. The only thing you have to do is dial in PEEP. How much PEEP does everybody need after intubation? 5. Okay, we need 5. And that's important. What is PEEP? Peak end expiratory pressure. It's just a little bit of pressure in the airway at all times to keep the little alveoli open, to keep from them being atelectasis, all right? So what you need to remember from this slide is that our tidal volume is typically 6 cc's per kilogram, all right? So if somebody weighs 100 kilograms, what should their tidal volume be? Is 6 times 100? 600, very good, great. And then people 5, and then they always go into assist control right after you sedate and intubate them. It's assist control. Okay? Does that mean anything to y'all? Okay, don't worry about it. I'm not gonna like go beat it over your head. Just remember assist control. All right. There's other settings like SIMV, which is intermittent mechanical ventilation, all that stuff. It doesn't matter. Once you sedate and paralyze them, you want the ventilator to do all the work, and so that's what assist control is. They're basically controlling everything. All right. All right. Now there's other innovation techniques that you might see, but this is not what we go for. But only like if they're doing an ENT procedure, they may do, or like an oral procedure, they're operating on somebody's mouth, like an OMFS or something, they may do a nasotracheal intubation. There's all kinds of, you've seen people try to practice on mannequins, little digital intubations. Never have I ever done a digital intubation, okay? I have seen these. This is nasotracheal. We've done them again when somebody's undergoing a procedure, specifically mouth surgery, and this is what it should look like. This is, they're using this is a Storz CMAC, which I love. It's a video laryngoscopy or video laryngoscope that basically uses a Mac blade, and you can look at it in real time, so you get real good screen use there. And then this is one that just lights up. There's this one. There's all kinds of different ones. There's an airway rifle, which sucks. Look at how they're intubating. There's all kinds of different techniques, but the video laryngoscopy is the best way next to DL. And there's all kinds of portable ones. You guys will actually get to practice with the portable glide scope that I borrowed from TCMC. It's called the GlideScope Go. It's a little handheld glide scope. It looks like this, but it's a handheld glide scope. The techniques are different. So remember I told you when we do direct laryngoscopy, you're inserting the blade and you're sweeping. We don't sweep unless you're using a CMAC. If you're using a glide scope, you don't sweep. The whole plastic piece is totally different. It's very hyperangulated, and if you sweep, you'll actually tear the tonsillar pillars and cause an airway mess. So with the glide scope, you're actually going to put it in midline of the mouth and no sweeping action. So it is a learned procedure, and there's some variances between direct laryngoscopy and some of these video laryngoscopes. Okay, we're almost done. So what's a difficult airway? What is it defined as? Tintinelli says it's 3 or more attempts at intubation. Most of the world believes 2 or more attempts, you're done. It's just not your day. Today you suck, but don't worry. Tomorrow you're going to be awesome again. And I've been there. I've sucked, okay? And then I've had really good days where I just nail it. So it's just the way it goes. Sometimes it's just not your day. So just step aside, turn it over to somebody. But if you're the only person and there's no one to hand off to, nobody more experienced than you, what are you going to do? You try again if they're not desaturating. If you've oxygenated them well enough and they're not desatting, you can try again. There's no harm in that, right? That's okay. The worst thing you can do is not recognize it and put it in the tube in the esophagus, or they're desatting and you don't know when to stop. Okay, if you're desatting, you need to bag them back up, or maybe you need to use an extraglottic device. Okay, do something else. All right, just don't keep doing what you already did and have failed at. Don't keep doing the same thing over. That's the definition of insanity, right? Right? All right, mechanical ventilation, we talked about it. Just remember assist control. And what was their tidal volume amount? 6 cc's per kilogram. And what's the rate typically? Yeah, usually we'll do 12 to 15, but we'll adjust it based on your blood gas. But initially, you don't know what that's going to be, so at least do like 12 to 15 breaths per minute. Do you think we have to extubate very often in the ER after we've intubated? No, rarely done in the ER. I've only done that once, and that's when I happened to be walking by a room, and they're like, "Oh my gosh, so-and-so, quit breathing." And I didn't know it wasn't my patient, but I put a tube in real quick, and it turns out she had just accidentally gotten the wrong dose of morphine, and they put her into apnea. And so once we were able to reverse that, then we were able to extubate her, no problem. And that's really rare. We don't usually extubate. Usually we're intubating for a reason. All right. Briefly, I'm just going to talk about surgical airway. What's the indication for surgical airway? Facial trauma most of the time, or if it's a last ditch, you've tried every other method. Dr. Love had to do a crike on a patient out in Brady who had anaphylaxis, and by the time he got to the ER, he was so swollen that there was no airway devices at all, none of them that would fit, including, I mean, he was just so edematous, so she had to crike him, and she saved him. She did a great job, because she's awesome, but, you know, that's another indication, right? So it's an emergency surgical procedure, and we're going to practice this during our lab. Okay, we do a vertical 2 centimeters incision right over the skin after you palpate the landmarks. How do we figure out where the landmarks are? There's different techniques, right? They have maxillofacial trauma. It's really hard to start at the chin and go down. So a lot of times I'll start at the sternal notch and go up. And what you'll feel is a little prominence, and then right above that is the cricothyroid membrane. So it's between the thyroid and cricoid cartilage. And so it's a little membrane. How big is it in the average adult male? It's only 7 millimeters tall by 10 millimeters wide. So even in an adult male, it's only 7 millimeters. That's why you have to use like a 602 or smaller, right? Because it's not very big. And in females, children, people like that, it's even smaller. You don't have much space. You'll see it on the caprines. I promise you, we'll go in for our ATM lab, and they'll have a 7.0 ET tube there. The caprine weighs 40, 50 pounds. It's too big for the airway, but every single trauma lab, that's what happens. You'll get the wrong size tube and you'll have no alternative. But anyways, you guys will be forcing it in there. But anyway, you do a 2 centimeter vertical incision through the skin, and then a horizontal stab incision through the cricothyroid membrane. And these are patients with maxillofacial trauma that you could not intubate. This guy, you know, very impressive looking, but if he's able to set up on his own and breathe, then he's doing okay. And so we try to sedate and paralyze him, and then guess what? He can't breathe anymore, but he still has a hole in the back of his throat that he's able to breathe out of. But if you're going to do any airway management on him, it's pretty obvious you're going to have to crike him. This is the one I share. This is my actual patient that I told you that we put somebody in a can't intubate, can't ventilate situation. This guy came in the same way, sitting up, breathing on his own. Okay, he got hit by a EFP or whatever, and it took out just the left side of his face. The right side of his face was completely intact. He was looking at me with his beautiful blue eye, you know, scared, and he was sitting upright. But he started becoming obtunded because when we took off his SAPI plate, it just crumbled. So he also had a big contusion across his abdomen. It turns out he had a liver laceration, and so he was internally bleeding. So he was becoming obtunded. And I was there with a pediatrician. They put a pediatrician as a Italian doctor that was co-located with me at my level 2 facility. Anyway, he's like, "Hey, I intubate middle airways all the time." He took a quick look at the guy. He's like, "I got this." We're like, "Okay." So guess what? We sedated him, we paralyzed him, and you can see we tried 1-2 times to intubate him unsuccessfully. Then we had to crike him, and we didn't have regular crike kits then. We had the new trach system. Have you guys ever seen that? It's a trach system. So what you do is you put this trocar in their neck. It's like a giant metal bevel. You stick it in their neck, and then you have to successfully each time dilate it with a bigger and bigger trocar so you get the right size, and then you put this little top on it. And so this guy's sats dropped into the 40s. And so I was like, "Oh my gosh, we caused an anoxic injury. This is terrible." Then we kind of forced it in his neck. We probably took out the recurrent laryngeal nerve. He probably could never talk again. It was months before we found out that no, he did not have an anoxic injury and he couldn't speak. And so, and I asked for permission to use his photo, but don't ever do this. You guys are so much smarter than I was when, you know, they taught us differently, but I wasn't prepared for this. So now we have the right equipment. We know when to use it. And this is why we're going to practice it here. So don't ever put somebody in a can't intubate, can't belly situation. I only tell you the story so you can associate it, because you'll never forget it, right? Because you'll never be that dumb, okay? But luckily, we were lucky, okay? Any questions about this? About this whole airway lecture? It's a lot. I threw a lot of information at you. Anybody confused? Yeah, I promise we'll reiterate this during our lab. You get to do hands-on, you actually get to intubate. You get to crike, you get to put your hands on the equipment, you get to do all the extra glottics. We'll do other things, other procedures too, like chest tubes so that you're prepared. We'll run some traumas where you're taking somebody off a spine board, doing the EFAS. We'll do some fun stuff where you're actually going through the motion of things. And I have my instructors are pre-programmed to tell you certain things that they should reiterate to help you on the exam. People did really well in exam 4. It's not like exam 2. Okay, exam 4 is a lot easier, and conceptually you're a little more excited about it. Any questions about anything? Okay, I know you're ready to go. I'm sorry I shaved into your time a little bit, but by finishing today, you guys will have extra time Friday, is my intent, okay? I'm here though all day, every day this week, so if you need anything or have questions, I'm around. Thank you.